How to treat and cure lung cancer. Cancer of the lung, like all cancers, results from an abnormality in the body's basic unit of life, the cell. Normally, the body maintains a system of checks and balances on cell growth so that cells divide to produce new cells only when new cells are needed. Disruption of this system of checks and balances on cell growth results in an uncontrolled division and proliferation of cells that eventually forms a mass known as a tumor. Lung cancer is the #1 cause of cancer deaths in both men and women in the US and worldwide. Cigarette smoking is the principal risk factor for development of lung cancer. Passive exposure to tobacco smoke also can cause lung cancer. The two types of lung cancer, which grow and spread differently, are small cell lung cancers, SCLC, and non-small cell lung cancers, NSCLC. The stage of lung cancer refers to the extent to which the cancer has spread in the body. Lung cancer symptoms and signs. In up to 25% of people who get lung cancer, there are no apparent symptoms at the time of diagnosis. In others, symptoms can occur from the cancer itself, from the metastatic spread of the cancer beyond its origin in the lung, or from so-called paraneoplastic syndromes that result from the production of hormone-like substances by the lung cancer cells. Common symptoms include cough, shortness of breath, wheezing, chest pain, and coughing up blood. Other symptoms can include shoulder pain, hoarseness, or difficulty swallowing. Symptoms of metastatic disease can include headaches, vision changes, seizures, weakness, or symptoms of stroke. Symptoms common to many cancers include fatigue, unexpected weight loss, and depression. Lung cancer symptoms and signs. Tumors can be benign or malignant. When we speak of cancer, we are referring to those tumors that are malignant. Benign tumors usually can be removed and do not spread to other parts of the body. Malignant tumors, on the other hand, often grow aggressively locally where they start, but tumor cells also can enter into the bloodstream or lymphatic system and then spread to other sites in the body. This process of spread is termed metastasis. The areas of tumor growth at these distant sites are called metastases. Since lung cancer tends to spread or metastasize very early after it forms, it is a very life-threatening cancer and one of the most difficult cancers to treat. While lung cancer can spread to any organ in the body, certain locations, particularly the adrenal glands, liver, brain, and bones, are the most common sites for lung cancer metastasis. The lung also is a very common site for metastasis from malignant tumors in other parts of the body. Tumor metastases are made up of the same types of cells as the original, primary, tumor. For example, if prostate cancer spreads via the bloodstream to the lungs, it is metastatic prostate cancer in the lung and is not lung cancer. The principal function of the lungs is to exchange gases between the air we breathe and the blood. Through the lung, carbon dioxide is removed from the bloodstream and oxygen enters the bloodstream. The right lung has 3 lobes, while the left lung is divided into 2 lobes and a small structure called the lingula that is the equivalent of the middle lobe on the right. The major airways entering the lungs are the bronchi, which arise from the trachea, which is outside the lungs. The bronchi branch into progressively smaller airways called bronchioles that end in tiny sacs known as alveoli where gas exchange occurs. The lungs and chest wall are covered with a thin layer of tissue called the pleura. Causes lung cancer. Smoking. The incidence of lung cancer is strongly correlated with cigarette smoking, with about 90% of lung cancers arising as a result of tobacco use. Pipe and cigar smoking also can cause lung cancer, although the risk is not as high as with cigarette smoking. Thus, while someone who smokes 1 pack of cigarettes per day has a risk for the development of lung cancer that is 25 times higher than a non-smoker, pipe and cigar smokers have a risk of lung cancer that is about 5 times that of a non-smoker. Tobacco smoke contains over 4,000 chemical compounds, many of which have been shown to be cancer-causing or carcinogenic. The two primary carcinogens in tobacco smoke are chemicals known as nitrosamines and polycyclic aromatic hydrocarbons. The risk of developing lung cancer decreases each year following smoking cessation as normal cells grow and replace damaged cells in the lung. In former smokers, the risk of developing lung cancer begins to approach that of a non-smoker about 15 years after cessation of smoking. Passive smoking. Passive smoking, or the inhalation of tobacco smoke by non-smokers who share living or working quarters with smokers, also is an established risk factor for the development of lung cancer. Asbestos fibers. Asbestos fibers are silicate fibers that can persist for a lifetime in lung tissue following exposure to asbestos. The workplace was a common source of exposure to asbestos fibers, as asbestos was widely used in the past as both thermal and acoustic insulation. Radon gas. Radon gas is a natural radioactive gas that is a natural decay product of uranium that emits a type of ionizing radiation. The types of lung cancer. Lung cancers, also known as bronchogenic carcinomas, are broadly classified into two types: small cell lung cancers, SCLC, and non-small cell lung cancers, NSCLC. This classification is based upon the microscopic appearance of the tumor cells themselves, specifically the size of the cells. These two types of cancers grow and spread in different ways and may have different treatment options, so a distinction between these two types is important. NSCLC are the most common lung cancers, accounting for about 80% of all lung cancers. NSCLC can be divided into three main types that are named based upon the type of cells found in the tumor. Adenocarcinomas are the most commonly seen type of NSCLC in the U.S. and comprise up to 50% of NSCLC. While adenocarcinomas are associated with smoking, like other lung cancers, this type is observed as well in non-smokers who develop lung cancer. Most adenocarcinomas arise in the outer, or peripheral, areas of the lungs. Bronchioloalveolar carcinoma is a subtype of adenocarcinoma that frequently develops at multiple sites in the lungs and spreads along the pre-existing alveolar walls. Squamous cell carcinomas were formerly more common than adenocarcinomas. At present, they account for about 30% of NSCLC. Also known as epidermoid carcinomas, squamous cell cancers arise most frequently in the central chest area in the bronchi. Large cell carcinomas, sometimes referred to as undifferentiated carcinomas, are the least common type of NSCLC. Healthcare professionals diagnose lung cancer. The history and physical examination may reveal the presence of symptoms or signs that are suspicious for lung cancer. In addition to asking about symptoms and risk factors for cancer development such as smoking, doctors may detect signs of breathing difficulties, airway obstruction, or infections in the lungs. Cyanosis, a bluish color of the skin and the mucous membranes due to insufficient oxygen in the blood, suggests compromised function due to chronic disease of the lung. Likewise, changes in the tissue of the nail beds, known as clubbing, also may indicate chronic lung disease. The chest X-ray is the most common first diagnostic step when any new symptoms of lung cancer are present. The chest X-ray procedure often involves a view from the back to the front of the chest as well as a view from the side. Like in the X-ray procedure, chest X-rays expose the patient briefly to a small amount of radiation. Chest X-rays may reveal suspicious areas in the lungs but are unable to determine if these areas are cancerous. In particular, calcified nodules in the lungs or benign tumors called hamartomas may be identified on a chest X-ray and mimic lung cancer. CT, computerized tomography, computerized axial tomography, or CAT, scans may be performed on the chest, abdomen, and/or brain to examine for both metastatic and lung tumors. A CT scan of the chest may be ordered when X-rays do not show an abnormality or do not yield sufficient information about the extent or location of a tumor. CT scans are X-ray procedures that combine multiple images with the aid of a computer to generate cross-sectional views of the body. The images are taken by a large donut-shaped X-ray machine at different angles around the body. One advantage of CT scans is that they are more sensitive than standard chest X-rays in the detection of lung nodules, that is, they will demonstrate more nodules. Sometimes intravenous contrast material is given prior to the scan to help delineate the organs and their positions. A CT scan exposes the patient to a minimal amount of radiation. The most common side effect is an adverse reaction to intravenous contrast material that may have been given prior to the procedure. This may result in itching, a rash, or hives that generally disappear rather quickly. Severe anaphylactic reactions, life-threatening allergic reactions with breathing difficulties, to the contrast material are rare. CT scans of the abdomen may identify metastatic cancer in the liver or adrenal glands, and CT scans of the head may be ordered to reveal the presence and extent of metastatic cancer in the brain. The technique appears to increase the likelihood of detection of smaller, earlier, and more curable lung cancers. 3 years of low-dose CT scanning in this group reduced the risk of lung cancer death by 20%. Use of models and rules for analyzing the results of these tests are decreasing the need for biopsy to evaluate detected nodules when the likelihood is high the nodule is not cancerous. Magnetic resonance imaging, MRI, scans may be appropriate when precise detail about a tumor's location is required. The MRI technique uses magnetism, radio waves, and a computer to produce images of body structures. As with CT scanning, the patient is placed on a movable bed which is inserted into the MRI scanner. There are no known side effects of MRI scanning, and there is no exposure to radiation. The image and resolution produced by MRI is quite detailed and can detect tiny changes of structures within the body. People with heart pacemakers, metal implants, artificial heart valves, and other surgically implanted structures cannot be scanned with an MRI because of the risk that the magnet may move the metal parts of these structures. Positron emission tomography, PET, scanning is a specialized imaging technique that uses short-lived radioactive drugs to produce three-dimensional colored images of those drugs in the tissues within the body. While CT scans and MRI scans look at anatomical structures, PET scans measure metabolic activity and the function of tissues. PET scans can determine whether a tumor tissue is actively growing and can aid in determining the type of cells within a particular tumor. In PET scanning, the patient receives a short half-lived radioactive drug, receiving approximately the amount of radiation exposure as 2 chest X-rays. The drug accumulates in certain tissues more than others, depending on the drug that is injected. The drug discharges particles known as positrons from whatever tissues take them up. As the positrons encounter electrons within the body, a reaction producing gamma rays occurs. A scanner records these gamma rays and maps the area where the radioactive drug has accumulated. Bone scans are used to create images of bones on a computer screen or on film. Doctors may order a bone scan to determine whether a lung cancer has metastasized to the bones. In a bone scan, a small amount of radioactive material is injected into the bloodstream and collects in the bones, especially in abnormal areas such as those involved by metastatic tumors. The radioactive material is detected by a scanner, and the image of the bones is recorded on a special film for permanent viewing. The treatment for lung cancer. Treatment for lung cancer can involve surgical removal of the cancer, chemotherapy, or radiation therapy, as well as combinations of these treatments. The decision about which treatments will be appropriate for a given individual must take into account the location and extent of the tumor as well as the overall health status of the patient. As with other cancers, therapy may be prescribed that is intended to be curative, removal or eradication of a cancer, or palliative, measures that are unable to cure a cancer but can reduce pain and suffering. More than one type of therapy may be prescribed. In such cases, The therapy that is added to enhance the effects of the primary therapy is referred to as adjuvant therapy. Surgery. Surgical removal of the tumor is generally performed for limited stage, stage I or sometimes stage II, NSCLC, and is the treatment of choice for cancer that has not spread beyond the lung. About 10% to 35% of lung cancers can be removed surgically, but removal does not always result in a cure, since the tumors may already have spread and can recur at a later time. Among people who have an isolated, slow-growing lung cancer removed, 25% to 40% are still alive 5 years after diagnosis. It is important to note that although a tumor may be anatomically suitable for resection, surgery may not be possible if the person has other serious conditions, such as severe heart or lung disease, that would limit their ability to survive an operation. Surgery is less often performed with SCLC than with NSCLC because these tumors are less likely to be localized to one area that can be removed. The surgical procedure chosen depends upon the size and location of the tumor. Surgeons must open the chest wall and may perform a wedge resection of the lung. Sometimes lymph nodes in the region of the lungs also are removed, lymphadenectomy. Surgery for lung cancer is a major surgical procedure that requires general anesthesia, hospitalization, and follow-up care for weeks to months. Following the surgical procedure, patients may experience difficulty breathing, shortness of breath, pain, and weakness. The risks of surgery include complications due to bleeding, infection, and complications of general anesthesia. Radiation. Radiation therapy may be employed as a treatment for both NSCLC and SCLC. Radiation therapy uses high-energy X-rays or other types of radiation to kill dividing cancer cells. Radiation therapy may be given as curative therapy, palliative therapy, or as adjuvant therapy in combination with surgery or chemotherapy. The radiation is either delivered externally, by using a machine that directs radiation toward the cancer, or internally through placement of radioactive substances in sealed containers within the area of the body where the tumor is localized. Brachytherapy is a term used to describe the use of a small pellet of radioactive material placed directly into the cancer or into the airway next to the cancer. This is usually done through a bronchoscope. Radiation therapy can be given if a person refuses surgery, if a tumor has spread to areas such as the lymph nodes or trachea making surgical removal impossible, or if a person has other conditions that make them too ill to undergo major surgery. Radiation therapy generally only shrinks a tumor or limits its growth when given as a sole therapy, yet in 10% to 15% of people it leads to long-term remission and palliation of the cancer. Combining radiation therapy with chemotherapy can further prolong survival when chemotherapy is administered. External radiation therapy can generally be carried out on an outpatient basis, while internal radiation therapy requires a brief hospitalization. A person who has severe lung disease in addition to a lung cancer may not be able to receive radiotherapy to the lung since the radiation can further decrease function of the lungs. A type of external radiation therapy called the gamma knife is sometimes used to treat single brain metastases. In this procedure, multiple beams of radiation coming from different directions are focused on the tumor over a few minutes to hours while the head is held in place by a rigid frame. This reduces the dose of radiation that is received by non-cancerous tissues. For external radiation therapy, a process called simulation is necessary prior to treatment. Using CT scans, computers, and precise measurements, simulation maps out the exact location where the radiation will be delivered, called the treatment field or port. This process usually takes 30 minutes to 2 hours. The external radiation treatment itself generally is done 4 or 5 days a week for several weeks. Radiation therapy does not carry the risks of major surgery, but it can have unpleasant side effects, including fatigue and lack of energy. A reduced white blood cell count, rendering a person more susceptible to infection, and low blood platelet levels, making blood clotting more difficult and resulting in excessive bleeding, also can occur with radiation therapy. If the digestive organs are in the field exposed to radiation, patients may experience nausea, vomiting, or diarrhea. Radiation therapy can irritate the skin in the area that is treated, but this irritation generally improves with time after treatment has ended.